Oh, he's on. Oh, we'll go to number another time. How do you jump on? I think when you first hopped on, it gives you that little thing that says join me. If anybody else knows how to do this, let me know. Let me see if I can press this button here. Oh, wait. I think I can add you. I should be adding you right now.
Aha!
Ah, what's going on, buddy?
What's up, buddy?
How's it going?
Sorry, I'm in a dark vehicle right now, but
Dude, that's all good. Patient care, patient care. It's all about patient care.
whatever it takes, man.
That's awesome. No, thanks for joining. I appreciate it.
Of course. How's everything going? What are you guys talking about?
So I kind of went over the vessel, how we inserted the device, or how the cardiologist inserted the device. Went over placement, went over correct positioning of the leads, and then we were talking about briefly mentioned the type of device, the shock coil versus not having shock coil, and what type of device this is. This is where you come in, my friend. I'm going to focus the camera back on here and go for it.
Okay. So I think we have a heart. That's what I see. No, I'm just kidding. So, plain films are very important, especially post-device implants. So if you guys ever do pacemakers, very important to always check a chest x-ray post-device implant. It's one of the things you don't really think about, but really important, especially as a resident or fellow, because it's your job to follow up with that patient. And one of the biggest complications of a pacemaker implant is a pneumothorax due to the proximity of the lung with the axillary or subclavian vein that's usually accessed. So that's one of the things I always first check on the chest x-ray is looking for a pneumothorax. The other thing you want to look for is the placement of your leads. So looking at this device, right away I can tell you that it's an ICD. It's a dual chamber ICD. The reason that you know that is if you look at the right ventricular lead, which is the lead that's just, yep, exactly, the one just off the spine. You see the thickness to that lead? That is the defibrillation coil. So if you ever get to look at a normal chest x-ray, that actually, oh, wow, my one of my electrophysiology fellows actually just joined. So hopefully I say this right, otherwise he'll make fun of me. But one of the things you got to look at is that thickness of the coil, and that tells you that that's a defibrillation lead. The coil should generally be within the ventricle because obviously your goal at that point is to detect ventricular arrhythmias and defibrillate them appropriately. But there are single lead devices that are often put in, and you'll see a pacemaker lead that actually has a defibrillation coil that kind of transverses the tricuspid annulus into the right atrium and into the right ventricle. Kind of an older school of thought is to put that one large coil in. Nowadays, more commonly, you'll see dual chamber pacemakers placed. And as the electrophysiologist, that fat ginger, which I told him he needs to change his name, but I love that. But he is an electrophysiologist, and he made a good point that this pacemaker lead looks like, or ICD lead looks like it's in the right ventricular septum. So normally we like to place the lead within the right ventricular apex, but obviously everything is not always the best. You can't always get an optimal placement. And so oftentimes when we put these in, we check certain parameters of the device to make sure that we're getting appropriate capture as well as sensing where the lead is placed. So sometimes the septum is the best place. Sometimes the ventricle or the ventricular apex is the best place. So it all depends. So that's the defibrillation coil in the RV lead. So if you look a little bit further at the spine, you'll see the right atrial lead. That generally sits within the right atrial appendage, most commonly. So that's how you know that this is a dual chamber pacemaker. So you have one lead within the right atrium, one lead within the right ventricle. There's a special type of pacemaker. So anytime you have a defibrillation coil with another lead, so a dual chamber device, I see this get left out a lot by both radiology and cardiology, is you need to look for the possibility that the device is a cardio resynchronization therapy device, or a CRT device. And what that device is, it's actually a 3-chamber pacemaker, where you have one lead in the right atrium, one lead in the right ventricle, and one lead that goes through the coronary sinus and actually paces the left ventricle from the lateral wall. Those patients usually are the patients that are NYHA class 2 to 4 heart failure with a significant cardiomyopathy, primarily less than 35%, with a evidence for dysynchrony on their EKG, primarily with a QRS duration greater than 150. Some people argue 120, but the majority of evidence supports 150. And so you always should look out for that. And so that's something I always look out for when I look at these. So a good thing to look at when you have these X-rays is to look at the 2 view, or the other view on this, on the X-ray, and you can potentially see that CS lead a little bit better.
I think that's a really good point, because I noticed that, again, I was kind of talking to him before, that there's so many different types of devices. The leads are kind of all over the place, and I was kind of stressing the fact that don't get bogged down on the types of devices. I mean, there's no way I know them. You're the expert, I'm not. But it's just knowing what types of chambers, or what chamber they're in, what, LV, RV, RA, where they are, that kind of makes a big difference. But that's good to know, because I've actually always wondered too, and I kind of pointed out before, that when that lead goes down into the apex for the LV, why patients have that, what's the purpose for that? So that's actually really good to know.
Yeah, so that completely changes the game, because a lot of the times it's easy for me to know that, because I've been trained to look for it. But when you have a patient that has a pacemaker, you look at their EKG, and primarily they're going to show what's called a left bundle branch block pattern on EKG. And the reason being is when you're pacing from the right ventricular apex, you're actually causing the right ventricle to depolarize faster than the left ventricle. And that is not physiologic. So normally, if you think about it, the heart should depolarize from left to right, right? So you have your main pumping chamber of the heart, which is your left ventricle. It should pump first, and then the right ventricle should follow. So basically, that's the amazing thing about the heart, is that it actually not only is a pump, but it acts as a suction also. So every time that left ventricle pumps, it actually acts as a suction to help unload the right ventricle. So when you pace a patient from the right ventricular apex, you're actually causing the right ventricle to depolarize before the left. And so that's what we like to call desynchrony. So patients that actually pace more than about 80% of the time from a right ventricular lead, they can actually develop cardiomyopathy, and they can develop significant heart failure. So knowing that a patient's going to pace like that much from the RV, they may need to consider doing a coronary sinus lead, which is the coronary sinus, if anyone doesn't know, is a structure in the right atrium. It's where the veins of the heart drain, and it actually transverses the posterior wall, wraps around the left atrial appendage and around the lateral wall. And you can put a lead in there, and you can actually depolarize from that lead first, and then pace from the right ventricle, and it almost acts like you're back into the way the normal heart functions.
Oh, interesting.
So the fat ginger said 40% of the time, if you pace, you should use a CS lead. So that's good to know. So that's the interesting thing about cardiology, is we have multiple different fields, just like you do with radiology, right?
Yeah,
You guys do fellowships, and he is specializing in electrophysiology, and they really are the guys that do the pacemakers. So he knows more than me, I will say.
He's specializing in awesome Instagram handles.
He's got very red hair too, so
that's awesome. He said also talk about his lead placement that may screw up radiologists sometimes. Fat Ginger, what are you talking about exactly on this one? because I obviously don't want to get screwed up. What lead placement were you specifically referring to? That may screw up radiologists sometimes. He's probably
Talk
typing
about
right
lead
now.
placement that may screw up radiologists sometimes. I think he's talking about the fact that the ICD coil lead is actually within the right ventricular septum, and
Oh,
not
like you mentioned before. Gotcha.
Yeah, so I think primarily you guys are pretty good with knowing where the RV is on chest X-ray. So I don't think you would be screwed up. I don't know who Fat Ginger's been dealing with, but
yeah, that's good to know. That I never like thought about that being in the septum. I just see two leads like that. I'm saying RA, RV, and then moving on next. A lot of times I'm just saying stable positioning.
yeah. So I think one thing from my standpoint, if I was to talk to you or other radiologists, I'd be I'd let you guys know, like, if you guys see a defibrillation coil, you guys should really look out for that CS lead, because I think you can really help a lot of people with your reports if you mention there's a dual chamber ICD with evidence for a coronary sinus lead, and then all these patients, like, because a lot of times we get patients that come in and they don't bring their cards with them. They don't even know what device they have, and so knowing that they have a CS lead and we don't know what their ejection fraction is because we don't have an echo, just knowing that they have that type of device means that they had a cardiomyopathy at one time.
That's
that can really help us. Yeah, really help us.
That's good to know. The other thing that I wanted to kind of touch upon, these the wires that are kind of just left over, that when you take out pacers, when you take out ICDs and you've left a wire in place, what is it, just because you just couldn't take it out? When does that happen?
So that's a great question, because obviously when you put these wires in, you have to remember what kind of complications can arise from that. And so the number one thing, first of all, is the more wires you put in, the more space is taken up, and the less vascular access you're going to have for future things. So sometimes leads have issues like they fracture or have insulation breaks. And if they've been in there for a long period of time, Fat Ginger, I'm not sure how long exactly before you can think about pulling these out, but I know if they've endothelialized and the screw is within the myocardium, you don't want to really be yanking these leads out. So
Sure.
Oftentimes we just leave them in there, and they're considered abandoned leads.
Sure.
So if that is the case, we just leave them in there, and then we try to put in other leads. But that makes a good point, and that's one of the reasons why they got rid of that big defibrillation coil lead that used to sit in the right atrium. Because if that lead ever got abandoned, the defibrillation coil leads are way bigger than the normal leads. So to abandon a defibrillation coil is not a good thing. So
makes sense.
So
makes sense.
Less is more, is always in medicine. Always in medicine. Do only what is needed.
Yeah, seriously. The other thing, have you heard about, somebody gave a grand rounds on it. I believe it was a pacer device that is actually just implanted into the myocardium, and that's it. It's just a little tiny, like, lead that I don't know.
Yeah, so that's actually a really cool thing. The Fat Ginger is actually putting those in. They're called the Micra, so it's a wireless pacemaker, a leadless pacemaker. And actually, you put I think it's a 22 French sheath within the right common femoral vein, and you access the vein and access the right ventricle, and you actually almost basically inject that device into the right ventricular apex, and it's able to coordinate with a normal pacemaker device to pace without any leads. And truthfully, I believe in the right patient that is going to be the way of the future for sure.
But there's no specifics on how to remove it, right? It's got like a 10-year battery life, something like that.
I actually I'm not sure. I'm positive the battery life is at least 10 years. They all use lithium-ion batteries, but
Sure.
I don't think you can explant it.
From what I remember from the conversation, the grand rounds that they're having, it doesn't seem like you can remove them. That's good information.
Yeah. It's really I mean, the field of electrophysiology is really crazy. As much as they like to call us the plumbers because we're the interventional cardiologists and they're the electricians, so they like to think they have this really fancy job. And I hate to give him a lot of credit, but they do a lot of cool stuff, and their field is just exploding with technology, and it's only going to get much more advanced with what they can do, and they can do some pretty amazing stuff.
That's awesome. That's awesome. No, good information. I appreciate it. Obviously, I'm nowhere. I mean, I don't know anything about this kind of stuff in the heart, so this is great. I'm learning while everybody else is learning on here. Any questions you guys had? Somebody's asking right now. I forgot to ask this question yesterday, but how many nighters did you pull comparison between university and medical school? Oh, I don't think I pulled any all-nighters as far as studying in college. I'm sure I was partying and I pulled all-nighters. Med school is a lot of all-nighters. And then you get into residency and you don't want to pull all-nighters, but you're working all night. Got a 24-hour shift on Sunday. It doesn't stop.
Yeah, I think you know, I used to think I pulled all-nighters in college. But then when I got to med school, I realized, you know, you can't learn this material in one night. So it really takes dedication. You have to be studying from the first day of the class to the exam. You have to be very good at time management. I had a lot of fun in med school, but I studied very hard. And it was the idea that I knew if I put in, you know, 5-6 hours a day, I could go out on a Saturday and, you know, still have mental clarity to do well on the exam. So I don't think it's good mental health to pull all-nighters, truthfully. So I think one of the biggest skills you'll learn as you go through your career is how to be good at time management. And once you master that, things start to just become much easier.
Completely agree. The other two things that I wanted to touch upon, I'm not sure, you know, how you studied, but for me, I try, again, everybody's completely different. Whatever works for you guys, please go for it. But for what I noticed for myself, I'm not much of sitting down memorizing something in a book. I found a couple of other guys that I studied with in med school, and we just locked ourselves in a room and just went over the material back and forth until we knew it front and back. I noticed that helped me a lot. And so we had a lecture on it. It was like semantic memory versus episodic memory, which is semantic is you're basically reading a book, you're memorizing the material. That's it, you're done. Episodic memory is not only was I conversing with somebody about the material, so I was learning about the material itself, but I was also remembering the jokes that we had in between. I remembered, you know, what somebody yelled out, the wrong answer, we all laughed, blah, blah, blah. So I started remembering that stuff, which helped jog my memory when it came to the test. And then that helped me get to the answer. Again, that's just me, however you guys want to do it. And the other thing that I learned, if you're the smartest person in the room, go to a different room. That's, surround yourself with smart people. Don't be the person who's like, I know everything, I'm going to teach you guys everything. No, absolutely not. That's why I got Dr. Mahan on right now, cardiology on call. I'm getting owned right now in cardiology stuff right now. The Fat Ginger's owning both of us right now because we always want to absorb information from other people. Never be the smartest person in the room. Always always find different avenues to gain more knowledge.
Yeah, that's such a great point. And, you know, the Fat Ginger, he was my chief when I was when I'm in cardiology fellow last year. And one of the things that made cardiology so fun for me was his constant, you know, he'd be like, Jay, what do you think this is? Like, come on, we got to figure this out. Or let's go to the floor and like find some cool case. Like he had a lot of passion for cardiology, and, you know, he made it fun. And med school kind of sucks, you know, like there's a lot of pressure on you to pass the step and whatever else. But then once you get into residency, you finally actually start to practice medicine and you meet other people very similar to you, and it just becomes much more fun. And, you know, you really enjoy what you do. And once you enjoy what you do, the medicine becomes easy.
Oh, absolutely. 100% agree. If you perfectly said, like once you find your passion, what you love, I will nerd out over an MRI. I will be sitting there like nobody has any clue what I'm doing, but in my head, I'm just like ecstatic going, holy crap, I just figured this puzzle out, whatever. I'm looking at 30 different sequences. And then I can be the guy right after to go and, like, you know, put a drain in whomever, you know. and I just nerd out like crazy. I love when I'm in the reading room, and I tell this to all my other junior residents, don't be just sitting at your computer, only looking at your cases and then going home at the end of the day. Go to every single person, every single station, ask them, yo, what was something interesting that you saw today? Tell me something, pin me on whatever. I welcome that. I told people, I'm like, quiz me, pin me, do whatever. Tell me, I'm wrong, and that's how I want to remember it. If you get something wrong one time, trust me, you don't forget that again, especially when you're in the hot seat in case conference. If you get it wrong, you will not forget what the right answer was.
That is preaching right there. That is exactly what I tell every medicine resident when they have to read an EKG and they're so scared to read it in front of attendings. I told them, like, I made myself look like an idiot so many times, but that's why I remember it. Like, those times when you screw up are the times that you're going to remember. And one of the things that an attending always told me, and it really stuck with me, and I think it did a lot for me remembering things, was if you see a cool case, like say I see severe mitral regurgitation or mitral valve prolapse, like I read the guidelines or I read an article on it that day. And so I wasn't reading, 5 hours a day or a textbook because, I was, doing a lot of other stuff. But I went home, I took 30 minutes and I read about mitral regurgitation. And every time that happened, I remembered it. And so I think that made me take a huge jump in cardiology, was once I started realizing, like, I don't have 5-6 hours to read about, 8 different things. But every day, if I do 30 minutes on a cool case that I did, I can read about it and then apply it to the case that I just saw. And that made me realize, this is cool, man. The next day I could tell the attending all the stuff that they didn't even remember.
Absolutely. Absolutely. And the other main thing that I wanted to kind of stress to everybody, in a way, first of all, me doing these live cases for you guys every day, case of the day, not only do I love paying it forward and, teaching all this good stuff, I want to make radiology fun. Now we're making cardiology fun, but also it keeps me on my toes. If I don't know what I'm talking about, why the hell should I be telling you guys or, teaching you guys about this kind of stuff? So I have to be on my toes at all times. I need to know the information. So number one, if you can teach somebody something, that's when you really know something. You can read a book 100 times over, but if you haven't actually said that out loud to somebody and you haven't actually gone through the whole process, you may not know it. You won't know what you don't know until somebody calls you out. So seriously, go over stuff all the time. Start dropping knowledge on other people. Have them do the same. It's going to go a long way. Trust me.
That's so true, man. And I remember a lot of people made fun of me when I started this page and, sharing knowledge about cardiology, and everyone's calling me a nerd. And, I love it. I embrace it now, man. I am a cardiology nerd because I truthfully love cardiology, and I love being able to, like, when these med students message me and I'm able to tell them like something cool about cardiology, or, a lot of people are wondering about the lifestyle and, if it's for them. And, I'm able to tell them first, I'm a fellow. I am on the front lines and I can be truthful with them and I'm not sugarcoating anything. And, it's awesome to be able to meet like yourself and, some other guys that I've met on social media, and they've kind of really, made me realize our generation, this is going to be a great way to teach the future doctors of America.
Oh, 100%. And you and I kind of talked about this before. We need to just keep figuring out different avenues. It's not all about just, I'm not here trying to curate a bunch of amazing stuff, show fancy cars, nothing like that. It's all about just paying it forward for you guys. And this is such an amazing venue, amazing avenue to do it. I wish we had something like this when we're going through like med school and things like that.
I know. Wow. I can't even imagine having this access to seeing these cool IR cases that you post. And, I didn't realize truthfully how much radiology was in cardiology. Like, we do so much imaging, and then seeing the radiologist page and your page and all these connections that we have. And it's so cool to we just recently did a collaboration, a nice case with an IR attending, and it was a nice dual specialty. We fixed something cool, which I'm gonna show soon. You can keep you guys on your seats, but it was cool to see what they can do. And I will say, especially for you, if when you're going into interventional radiology, you should try to get some vascular exposure. Talk to the interventional cardiologist, talk to the vascular surgeons, and see, like, find out their little tricks and their little, what they do. Because when you're a proceduralist, what I've realized is it's easy to do like the run-of-the-mill procedures, but when you run into a complication or you run into a complex problem and how you deal with it, that's what's going to make you, top notch or not. And the more people you expose yourself to now, the better.
100%. Fellowship, and I'm going to learn this real hard in a couple months when I start fellowship in IR. But what I've noticed that when you're a resident, you're still kind of protected, that kind of stuff, and you're not dealing with the daily day-to-day grind for your subspecialty. And fellowship is all about learning from your complications and knowing how to manage them. I can place a line like no other. I mean, I've literally timed it to place a line. It's not that, I mean, it's kind of, you're going through the same steps over and over again, but it's all about knowing how to fix whatever is going wrong at that moment, because that quite literally can mean life or death, literally, for that patient. And it's scary to have that, literally a patient sedated, having no clue what's going on, and their life is in your hands sometimes. So real quick, I also wanted to add, for anybody who's passionate about whatever field it is, a lot of people ask, do research, whatever it is. Absolutely. Do your research, do papers, do posters, but find a mentor. Find somebody that you can latch onto and literally just suck the knowledge dry. I found my mentor third year of med school just fortuitously. I just happened to stumble upon him as an interventional radiologist. I still talk to the guy. We still go out to lunch. We still do stuff. He's taught me everything. I would go up to him, and I just actually talked about this to somebody yesterday. Even on my trauma night float, when I was a third-year med student, I would do my, whatever it was, 12 hours, something like that. And then at 8 a.m., I'd be off shift. I'd sleep for like 2 hours, and then I would go straight down into the angio suite and start doing IR cases for the rest of the day. And then I would go back down to, trauma surgery. And I would sometimes be in the, hospital for like 2 days, sorry. I just got distracted because it looks like Instagram is telling us we only have 2 minutes left on this thing. I didn't know there's a time limit. Yeah.
Yeah,
so,
I mean, that's a really good point. And I realized that also in cardiology. I met my mentor the first year, and the way that he did his procedures was he always made me realize, he's like, treat every day in the cath lab like it's your first day. And remember, these are people that you're doing things to, and you have to be ready to like accept the complications of what you do. And I emulated everything he did, and I wanted to be as good as him. And I knew if he did it by the book, at least if I did it to his book, I would be really good at what I did. And I did it to the point where I respected him a lot, and he went out of his way to call a program for me and get me into the door when I was interviewing for interventional cardiology. And I owe him so much for the spot that I got, because 100%. He looked out for me. And he, getting someone to call for you in medicine is huge.
100%, man. I totally agree. Instagram's telling me I only have 40 seconds left on this thing. I didn't know there was a time limit on this. Dude, I appreciate you coming in live. We're going to be doing this all the time now. This was awesome. I learned so much, and I'm sure everybody else did as well. Fat Ginger, thank you too, man. You dropped a bunch of knowledge on us.
Don't give him too much credit, man. Don't give him too much credit.
That's awesome. Hey, guys, we're going to continue this again. We'll do this again. I promise you, case of the day, we're going to keep going. We'll do a lot of more cardiology